Hey, hello everyone, and thank you for joining us to our last and fourth session of the Learning Collaborative. Again, this Learning Collaborative is presented to you by the National Center for Health and Public Housing. And today we will be discussing our last session on enhancing the use of clinical preventive services for older adults. So this is just a reminder that the content of this Learning Collaborative is 100% financed by HRSA and do not necessarily represent the official views of HRSA, HHS, or the U.S. government. The mission of NCHPH is to strengthen the capacity of federally funded FQHCs and other health center grantees by providing training and technical assistance. And also with us today, we have Dr. Kevin Lombardi, who is in the line. We also have Jimoke Oladipo, who is also in the line, and myself, and we will all be co-moderating today's session. And this is just a kind of reminder to everybody that all participants are muted upon entry. Please make sure that you engage in the chat just the same way that we've been doing in the last few sessions, not just in the chat, but also verbally. Please, this meeting is also being recorded, and the slides and the recording link will be sent to you all after today's session. And now I'll pass it on to Dr. Kevin Lombardi to kick started with the presentation. Thank you.
Hi, everyone. Welcome back to our fourth session. And thank you all for your service to your communities. It is a beautiful day here in Virginia. I hope it's lovely where you are as well. And if it's not, we're going to try to brighten it up a little bit. Today, we are going to focus. Fide, could you go a couple of slides, 3 slides forward, please, to where we are here. We have followed Mrs. Tiller, our patient, through a variety of challenging incidents in her recent life. Mrs. Tiller was originally our outpatient clinic primary care patient. We learned about her chronic diseases, her disabilities, and complex patient needs. We visited Mrs. Tiller in her home and found that she lived in a home that had a variety of different hazards, trip hazards, fall hazards, and toxicity and poisoning hazards as well. Despite our best actions, Mrs. Tiller experienced fall, and that fall resulted in a hip fracture. We learned last session that she had received that hip fracture and that she would be receiving a surgical procedure to fix that and would be receiving 2 weeks of therapy. Specifically, it was an intertrochanteric fracture, and she experienced the successful fixation of that fracture. Fide, if you go to the next slide, we can go right into Mrs. Tiller's day. Today, we will be following Mrs. Tiller in the time after her emergency room visit when she's in the hospital and in rehab. Through the story of Mrs. Tiller's experience with this very common injury in older adults, we will have discussions about the minefield of risks that she is about to enter and the things that we can do to sweep that minefield and maximize Mrs. Tiller's ability to go home safely and to live independently. This is where we started last week, and just to briefly review it. 2 weeks after Mrs. Tiller's home visit, her primary care provider received notification from a physician at your local hospital's emergency department. She provides the following updates. Mrs. Tiller was seen in the ED after she experienced a fall. The fall occurred in her bathtub where she slipped, bumping her head and landing on her left hip. Her diagnosis was an intertrochanteric hip fracture with internal rotation. She didn't lose consciousness, and her mental status was noted to be markedly reduced in the emergency room. She exhibited severe confusion and agitation, which is not uncommon as a sequelae to this injury. Just to go over some important points here. First of all, we discussed on our last session that her mental status was reduced and that this patient was at risk of a condition called sundowning, in which older adults who experience an injury and an abrupt hospitalization can have issues with mental status and awareness that can put them at risk of severe complications, both through exacerbation of their existing chronic diseases and their new risk of injury. Um, and Mrs. Tiller was admitted to the hospital for that fixation. So we'll go forward before I go too much into fixation. So I was very specific in why I put this case together this way. When I practiced, when I was in training, the hospital and outpatient services, residents were able to log into both medical record systems. A variety of staff there were, but primarily the residents. And the important role there is we were able to pull records and see records at the hospital where patients were almost always admitted, and and the outpatient clinic where we saw them. Now, in many cases, in rural areas in particular, smaller communities, that will be the case. I practice in a small rural community, and with few exceptions, we almost always knew where the patient was going to the hospital, and it was through our facility. For those of you in urban areas, it's a little bit more complicated, but there are often one or two or three hospitals that the patient can go to in your area. Know the staff at your facility who may have approved access to pull those records and look at those records and integrate that into your patient care. Have conversations with residents, shared staff, and so forth. And I will add another point that allowing staff to have this shared access does improve patient care and speed up information sharing amongst providers. So we get a look at these notes. So let's look at how things went for Mrs. Tiller. So this is an operative note as we would see it in medical records. The preoperative diagnosis, as we discussed, was an intertrochanteric femur fracture. Post-operative diagnosis, same. No new diagnoses, no issues, new issues found. And she received a open reduction and internal fixation of right intertrochanteric femur fracture using a short cephalomedullary nail. Her anesthesia was general endotracheal anesthesia. Now, Fide, I'm gonna put you on the line for a second. That procedure, I'm thinking of the amount of jargon in there. Does it make much sense to you?
Very complicated, especially if you don't, well, for me, right? Like, if you don't have like a very clinical background, yes, it can be very complicated to try to understand.
Well, here's the challenge. When you're looking at the records, this is what you're going to see,
Mhm.
regardless of what provider you are. So let's go through a little translation exercise together. So starting with open reduction, that refers to that they surgically opened the patient, cut the patient's skin, they as opposed to a closed surgery, something like laparoscopic surgery. Of course, it's always open reduction in this case, and internal fixation, meaning when this patient fell, and when you see patients in emergency services who have a hip fracture, when they fall, often for especially this hip fracture, an intertrochanteric hip fracture, the leg will experience a reduction and a turn inwards, and that's because the patient's muscles are seizing up and pulling that bone. And that kind of gives a picture of just how severe the injury is and how painful it is for patients. If you'll remember last session when we looked at some of the X-rays, Jamoke pointed out that those bones looked a lot very sharp, and they can be very sharp. And you imagine that muscle pulling together, that's how incredibly painful this preventable injury can be. So, internal fixation basically means they opened her up and they put the hip bone back where it's supposed to be. And right intertrochanteric femur fracture, that refers to the injury she has. And the cephalomedullary nail, that's the specific nail that they put in to hold things together. And we'll get a look at those in the x-rays in a second. And the last note here says that anesthesia is general endotracheal anesthesia. Now, that's a terminology that pops up a lot, and it's very important for Mrs. Tiller and her risk of disease, or risk of complications. Fide, do you know what general endotracheal anesthesia is?
I can just infer that it has to do with like maybe they had to put a tube down her throat.
Mm-hmm.
Right?
Mm-hmm. 100%. And that's how they, uh, so basically the patient is ventilated. And the way that looks is for this procedure, a anesthesiologist puts that endotracheal tube, sedates that patient, puts that endotracheal tube in, and respirates for the patient during the surgery. When you see it in the surgery, the anesthesia has its place here, and the surgeon is over here, and they work together as a team to manage patient care. Now, the anesthesia, though, tells you a lot about her risk. And in particular, when physicians don't need to, they do not like to give endotracheal anesthesia. And can someone tell me why? And I'll give this to the crowd and say, if not, Jamoke, it's your best guess. Why do we try not to give endotracheal anesthesia if we don't need to? I promise this is relevant to preventative health. Help me get there. Jamoke, why would I not want to put a tube into an older adult woman's trachea, a tube from the outside of the world into her lung, very close to her lungs and in her airway? Why would I? What are some risks that I'm introducing to this patient by entertaining that idea?
Further risk of injury and damage or infection, taking something from outside and bringing it in.
Oh yes, bing it, bam, boom, 100%. And I'm going to start with infection, and I'm going to hand it to the crowd. Fide, I think we had a participant that mentioned this as Jamoke's gun was smoking.
Yeah, Mary also mentioned high risk of infection, tearing tissue.
Mary, could you give me your perspective on this? Why did you think to say those two things?
I think she might have had to pop off right now, actually, but
Oh, that's fine. Well, Jamoke, you mentioned the same thing. Do you mind answering the same question?
Well, for an older adult, she's already higher risk, but you're taking a foreign object and you're putting it inside of her.
Mm.
Um, so any slight, so for someone who's already high risk, any wrong movement could lead to injury, and she won't heal as quickly as other patients. So that can invite further infection.
100%. And the condition that really scares me with these patients that is a preventative medicine priority in all contexts, in the field, at the home, in the outpatient clinic, in the hospital, is prevention of pneumonia. Pneumonia is a killer for patients in this age group. And regardless of vaccination status, of course, vaccination for pneumonia leads to reduced risks, both in the frequency and the risk of getting the infection and the severity of the infection. But it is still a primary cause of morbidity and mortality for this age group. And if you walk into the hospital your statistical chance of getting pneumonia goes up every step you take. When you're in the ED, you're exposed to patients, you're exposed to internal environments. When you go into the hospital, you're exposed to in hospital infections, which are also major killers of these patients, major causes of morbidity and mortality. And when you put that tube into their airway, you take that risk and you accelerate it greatly. When a patient like Mrs. Tiller is in the hospital, her lungs are not inflating all the way. She's in her bed all day. She's moving very little often. And post surgery, the 1 or 2 days there, she can't move much. So all of her lung fluid is just sitting there, and she has just gone through anesthesia. So she's at an increased risk because of that. When the tube goes in, that risk increases. So, as a clinical provider, when you are seeing patients after they have been in the hospital, and you know that they have had anesthesia, they have had a endotracheal procedure, be on alert for pneumonia. They are at severely increased risk. The pneumonia can develop in days or shorter, and onset of symptoms can be severe. You should be aware that patients in your clinic, in your practice, who are experiencing this will start to have those symptoms come on pretty quickly. They'll start to have the coughs. They will have dry cough. They will have, depending on the pneumonia, dry, not dry, sputum, not sputum. Be very alert for airway symptoms. If patients start to experience cough, start to experience shortness of breath in particular, that is an opportunity for action, because that patient is at very high risk of developing pneumonia. Fide, did we have a comment or someone who had something to say? I did see a bubble pop up.
Yeah, we had a comment from Wendy mentioning they may not be able to get her off the vent once it's put in. That is another risk. And also the lungs become weakened, which we just discussed.
Wendy, you are correct about both things, and I was wondering if you could enlighten us with your perspective, please.
Well, again, I witnessed this very case. Not Mrs. Tiller, but someone else. And I do know that after the surgery, when that person was taken into recovery, when they tried to remove the vent, she could no longer breathe on her own. So they had to keep the vent. Now, apparently, there are two different ventilators that they use, one through the surgical process and one when you intubate someone who's not having a surgery, because what happened is they could never take the surgical vent, they could never remove it. So they had to keep her on this vent, which was, I guess, a little more uncomfortable, which meant high levels of fentanyl.
Fentanyl?
Fentanyl,
Ah.
yeah.
So
And
she
the
was sedated.
fentanyl
She was sedated long term after this procedure.
at very high doses,
Mhm.
because the doctor said that it would be inhumane if they did not give her as much fentanyl, because the pain from the vent was excruciating.
Oh yes, yes. And
And
yes, please continue. Continue.
this went on for a very long time. In fact, well, I'll tell you right now because it was my mother. Um, I I was called home, told that they couldn't get her off the ventilator, and we watched for a few weeks while they would try to reduce the what is it, fentanyl?
Mm-hmm.
Yeah,
Sedation.
tried to reduce the fentanyl, and were unable to do so because every time they tried, she would have some kind of a reaction.
Mm,
So at the time we were about ready to disconnect the life support, and the day we were ready to sign the papers, miraculously, for some reason, she started breathing on her own. So they were able to decrease the flow and eventually able to get her off this ventilator. However, now come the complications.
mm-hmm.
Through being unconscious for all that time, she was unable to eat. She was unable to speak. She had lost the use of her muscles. Um, there were a whole plethora of things that she had to be retrained to do all over again. Now,
Mm-hmm.
I will tell you too that eventually things did come around, but it took a long time. And she was never able to go home alone. And she even had a husband um, living with her, but the house
Yeah.
was unsafe. It was not handicapped accessible for the types of handicap she now had.
Mm-hmm.
Um, she was never able to walk again without the use of a walker. Um, but we had, before they would release her to her home, I had to call in I not architects, contractors to come into that home and totally redo where her bathroom door was, make sure she didn't have a bathtub, she had a shower, make sure everything was wide enough to get the wheelchair through. It was quite the process.
Mm.
But without a younger child, they were not going to allow her out of that nursing home, and she would have had to been in care forever.
You know, Wendy, I cannot tell you how many times I have had your mother, the equivalent of your mother's experience in my care. And this speaks very deeply to the risks that patient experience as soon as they are intubated, as soon as they are sedated. There are significant risks of extended ICU stays, and those lead to severe decompensation, severe undernutrition, and severe respiratory decompensation. You mentioned the need for fentanyl. And sedation management is a minute by minute conversation in the ICU. It's an everyday conversation about how to get that sedation down and how to balance that with the reality of what the ventilator needs to do to keep the patient breathing. Now, being on a ventilator is traumatic, and it's not just traumatic in a psychological sense. It is traumatic in a physical sense. Those little alveoli are like balloons. And when you are forcing air in, no matter how careful you are about engineering it, you do damage to it. The patient's lungs become sclerotic and uninflatable over time. And in particular with COVID, we saw patients' lungs go from very elastic after months of being intubated to being really like trying to inflate a soda can. It was impossible. And trust and believe, every day you are on ventilation, you are experiencing the micro injuries to your lungs that cause that sclerosis and cause that long-term disability. That's the reality of patients like Mrs. Tiller. A hip injury can very easily lead to that scenario where the patient has a procedure, has to be intubated, cannot be unintubated. Very common story, very common story. And as Wendy alluded to, the engineering that needs to go into effect to allow that patient to transition into a safe home environment is often monumental. and requires very specific care and very specific attention, it is very difficult to discharge a patient like Mrs. Tiller or like Wendy's mother back home when there isn't home support. That's because the number of tasks that need to be done in the home requires full-time attention. And if patients can't receive a full-time attendant, it's very difficult to have realistic expectations about their recovery. In fact, it will be a barrier to discharge. We will not discharge patients if they don't have a safe environment home. And that might sound a couple of ways, but remember, the longer Mrs. Tiller is in the hospital, the larger her risk of infection, the larger her risk of fall, and so forth. So the family and home environment is important for a range of issues, but having that support and making sure that family members are informed and engaged makes things a lot easier on the other end. And I'll say if there's anything else here. Either Fide or Jamoke, did you have any more thoughts before we proceed?
Well, Benvita put in the chat, is there a reason that the orthopedic surgeon couldn't do this in a more non-invasive manner? Sorry, laparoscopically, or is it because she needed the screws that the intubation was done?
When I was training in a rural area, we only had access to laparoscopic surgical procedures for this if we transferred a patient to an urban area that was quite far. That introduces new risks. If this patient were to experience this fall in downtown Boston, that is what she would receive. If she received it in Danville, Virginia, this is the procedure she would receive. Yes. All in all, I don't know what the percentages of the procedures are. The gold standard is the laparoscopic procedure because it has a smaller surgical incision and a much smaller risk of surgical site injury. But those equipment are not readily available in most of the country geographically. Very good point, though. Very good point, and noted. Was there anything else before we proceed? Let's go. Next slide, please. Okay, so let's take a look at the rest of the note here. 73-year-old female sustained the fracture following a ground level fall. They confirmed it by imaging, and they noted the fracture, and they performed the procedure. Surgical notes are very straightforward. It's interesting, when you read an internal medicine note, it's like reading poetry sometimes. They can get very creative and very detailed. Surgical notes are very straightforward and straight to the point, much like the individuals at times in those different fields. Estimated blood loss. For patients like Mrs. Tiller, they often take blood thinners. Warfarin is an example that is commonly used in places like where I practice because it's cheap and it's covered by insurance. There is a risk of increased blood loss when patients take those medications. Mrs. Tiller did not, and she has about 50 milliliters of blood loss. Typically, anything less than, when I'm reviewing records as a primary care physician, anything under 200 does not raise alarm with me. But that's, of course, patient and situation dependent. She experienced no complications, so normal surgery. And looks like she is going to have early mobilization with physical therapy, DVT prophylaxis, and a follow-up orthopedic clinic in 2 weeks. Now, my question for the group, and Fide, this will be you if there are no takers, is when you read this plan, pain management, early mobilization, physical therapy, and DVT prophylaxis, follow up at the orthopedic clinic in 2 weeks, what comes to mind for you and your priorities for Mrs. Tiller?
For me, is how do we get her to at least try to attend the first follow-up appointment?
Mhm.
And also the medications, the pain management medication, the mobilization with physical therapy, like all of that is just, it comes to my mind, like how do we get Miss Stiller to start with the therapy, with the recommendations that were given to her in the first place?
Yeah, you notice you mentioned something that's missing from this. I don't see anything on this plan that discusses discharge planning home. I don't see anything about home health. There's no
Mhm.
discussion of family members at home. It seems that the provider is totally unaware of this information, and it seems like it has not been put in the medical record. So that concerns me because the risks you mentioned are real. This patient will not be successful if the discharge planning is not pristine. Pristine. And I don't see any extra recommendations or information about that, which means it was not a priority in this provider's mind. I will say, when I receive a good surgical note, they are very specific about the type of PT and OT that they receive. The patient will receive. They are very communicative with their internal medicine colleagues about managing and changing existing chronic therapy, but that is not always the case. And this patient, it seems, her discharge planning was not prioritized in this documentation. Some other things. A DVT. Oh, I'm sorry. Did we have a comment before I progress?
Yeah, Benvinda mentioned, what about home health care nurse and transportation to her appointments, and why not in-home physical therapy? And
Oh yeah. Well, as you see, discharge planning was not a priority here. There's nothing about it. They likely assumed internal medicine took care of it. I hope internal medicine doesn't assume someone else took care of it. But Benvinda, you're talking discharge planning here, and you're mentioning services. Do you mind coming and telling us what you think Mrs. Tiller needs at home to be successful? Oh,
what did she
I
say?
think no worries. Thank you so much for adding the comment. Is anyone else willing to jump in and tell us what mix would they put together? What cocktail of services would they provide to Mrs. Tiller?
Oh,
What is their wish list?
sorry about that. I can unmute now. I'm so sorry.
No, thank you, thank you. And we know who you are, but we want to hear it again. Please tell
Okay.
us who you are and who you serve and how.
Okay, so my name's Benvinda. I'm a certified community health worker. I serve Medicaid and subsidized health plan population in Massachusetts and all the cities and towns, helping to coordinate services, whether they're inpatient getting discharged or out in the community. We try to assess and help the members, in this case, patients, with everything they need to address social determinants of health and everything else, transportation, whatever it is they need to be healthy, and educate them on how to advocate for themselves too. So a lot of education is involved as well.
And if I remember correctly, well, I know where you're from. Can you tell us where in Massachusetts we're from? I had a guess.
So we work remote. Our corporate office is in Charlestown, Mass, but we're affiliated with Boston Medical Center. So we're the health plan for all folks that have accountable care, meaning that Medicaid and certain hospital groups form together to care for the patient as a whole, calling it accountable care.
Well, I will say that I predicted. I heard a little bit of New Bedford or Dartmouth in your accent.
Yeah, I live
got it
in New
wrong.
Bedford. No, I live in New Bedford, and that's where
Fide,
I'm
what did I
from.
say? Hey, what? Tell the
Yes,
audience what I said.
that I
Yeah,
have an
you,
accent.
yeah, yeah, well, he predicted it very well.
I
Oh,
said,
wow.
I have a feeling she's from New Bedford. I have
Yeah.
a feeling.
I am.
Well, the best seafood in America, by the way. But
Oh, thank you.
I want to ask you just for so people know, because we had a very interesting conversation with our Floridian colleagues that I really appreciated. That shows the diversity of challenges that CHWs experience. Now, I know that your area is an urban area. It has the best facilities, some of the best healthcare facilities in the world, and the state has very robust programs. And what I'm seeing as the challenge for a care coordinator in your situation is the complexity of dealing with that, getting the patient to the right resources for
Right.
them, and sort of engineering a supportive structure through education and so forth. Am I right in my understanding of that?
You're absolutely right.
And I'm wondering if you are sitting in Charlestown. Let's say it's the spring. You have Mrs. Tiller as one of your patients,
Mhm.
and let's say you have a conversation with the hospital, and they're asking your opinion. What are the services that are priorities for you and Mrs. Tiller? What's your Christmas list for Mrs. Tiller?
So the first thing I would recommend or would be in-home nursing, home health aid, so they can assess her for a home health aid. Also making sure that she has all her durable medical equipment in place, whether it's a cane or a hospital bed, things to make it easier for Mrs. Tiller, maybe to stay home and have all the support services she needs in place. I would probably bring in elder services so she can have long-term support, homemaking or whatever it is that she might need to live a more comfortable, healthier life for the duration of her lifetime, I would say. Making sure that she has enough food, transportation to get to her appointments, just, basic needs to help Mrs. Tiller stay home and stay healthy and avoid readmission.
And I will say that we have the same shared goals here,
Mm-hmm,
and that is independence uh, and sustainability for the
mm-hmm.
patient. Uh, and uh, and yes, thank you so much, and thank you for sharing and for serving your community, which is a lovely community, if I might add, especially
Oh,
this time of
thank you.
year. Lovely place.
Thank you. Glad to
Uh,
be here. Mhm.
Thank you. Fide, Rebecca said something about something that rhymes with schmelschmeaning, and it's very important for this patient. Rebecca, do you mind telling us why you want this specific thing for Mr. Tiller?
I have which Rebecca?
Oh, I'm sorry. Whoever thinks that Turungo. I'm so sorry about your name if I
It's
mispronounced.
okay. Nobody ever gets it. Don't worry about it.
Oh, could you tell us how to do it though?
Toronjo.
Tarangio. Okay.
Yeah.
Well, Rebecca Tarangio, thank you for joining us and for your service to your community. We would love to learn how you serve them.
How I what?
What do you do, Rebecca? How do you live your day? How do you serve
I
your
am.
community? I'm sorry.
That's okay. I'm a housing coordinator, especially terms of health coordinator, and in the process of becoming a community health work certified coordinator. And I've been
Lovely.
through this with caring for my elderly dad for years. Wound care to make sure there's no infection, to avoid, and I know some elderly individuals just won't eat. If they have to get up and prepare meals, they're not going to eat, and that's not good for them nutrition wise or healing wise or regaining their ability to be recuperate. They have to have the nutrition to be strong enough to recuperate. Somebody, home health, some physical therapy, occupational therapy in the home, as well as making sure that, they can't, the home is not prone to another fall. Also, what we found valuable, and we live in a very rural area, we contacted the Area Agency on Aging, and they provided some homemaker services. So the home stays neat and clean, to avoid infection and falls, as well as, getting mail. I mean, let's face it, if mail stays in the mailbox, people are going to wonder, what's going on, and bills aren't going to get paid. And then she's going to be in a world of trouble otherwise. Probably, some assistance from an agency as far as helping her with just general daily living, situations, bill paying, meals, keeping the apartment or house tidy. Doesn't have to be white glove, but tidy.
Yeah, I couldn't agree more. And you mentioned a couple of things that I think are really worth hammering a little bit. And the thing that really grabbed my attention when you said house cleaning is I'm a single dad. Let me tell you, I do a lot of picking stuff up off the floor. A lot of who knows? There might be a plate, a glass, some hot sauce. Who knows? There's always kids put stuff on the floor. And I'm 38 years old, and let me tell you, that lower back gets me sometimes. I am not a 73-year-old woman who just got a hip fracture and internal fixation. It is going to be really difficult for her to do the stuff that she may be used to doing. And bending over and picking stuff up may not be a priority if it causes 4 out of 10 pain each time you do it. And if she does manage to do it, it's going to be hard. It's going to be really hard on her. So housekeeping, I think, is a very kind thing for that patient, because it lets them enjoy their recovery. Recovery is hard. Make it as easy as possible. And 2, what a benefit to them as far as risk mediation, because it is very easy for someone to just, I don't know, put something small like a shoe or a cup to the side, trip on that, and re-injure that hip. I have seen it, and it seems like a silly story each time. Tripped and fall at home is the tagline that is in the medical record each time. Another thing I wanted to ask you about, Rebecca, is you mentioned that when this happened to your family, that this was in a rural area. My question for you is, was it challenging to find the services that you needed?
Yes. In the frequency that we needed, because they are spread so thin. There are services, but you only get so much because they only have so much available. So it was spread pretty thin. Ironically, we did have, he was a veteran. We had some VA assistance with kind of an emergency. They called and checked on him. I'll put it this way. They were supposed to call and check on him every day. But he ended up in the hospital, and they called 2 weeks later and said, "How is he?" I said, "Been in the hospital 2 weeks." So it was, we had, fortunately he had me on speed dial, and would, we were close enough that we could get there on an emergency basis, but he also had one of those life alert type things that if there was an emergency, he pushed that and we were good to go. So that was also beneficial.
That was good planning, Rebecca. That was very good planning. And I will say, for almost every CHW, social worker, or a budding professional, they have been able to make robust use of their skills in their own personal and family lives. And that's a benefit for all of us. Thank you for sharing that. I performed my medical training at the George Washington University, urban area, urban hospital, not a safety net hospital too. We had safety net people, but it was a mixed urban environment. residency was at Danville Regional Hospital in the southern part of Virginia. This is a rural area, in many ways different to where I trained in medical school. And the thing that got a chuckle when I was first starting is when I was designing my discharge plans for patients, I would put this whole list of things. You know, we need a home health all day for 2 weeks, all day and night. I need PTO2 Tuesdays and Thursdays. I'd be very specific. And the reason why I got a chuckle is because those just were totally unrealistic expectations for what were available in the area. It was unrealistic. This was a not a densely populated area. To get someone in the home, chances are they needed to drive 45 minutes to get there. Staffing was a constant challenges at the organizations we used for this. And they often just were not able to get to a patient even after we had arranged those services. Those were common issues that were not unique to where I practiced. They are a reality of practicing in many rural environments throughout the country in all 50 states. Discharge pad planning is particularly difficult when you don't have the things to connect patients to because of that frustration. Uh, it also emphasizes the importance of the family collateral. I can think of the difference of the practice environment in the urban and rural areas that I have practiced. And what I can say is in the rural area, I've relied a lot more on family members. And my relationship with the family members, it was often a very good use of my time to make those phone calls because they were so important to patient care. That's something to keep in mind, that there are very different dynamics that affect the patient going home. Your community will be different based on a number of different dynamics. The importance is that you know the environment and you know what is available. Uh, Wendy, I'm sorry to throw something at you, but you practice in a rural area in the northern part of Florida. I was wondering if you had any thoughts on the challenge of finding resources that may not be in your backyard.
Oh my goodness. We have a very difficult time getting in-home services. Basically, because we're so remote from where they're all offered. We don't have visiting nurses down here. I mean, unless a person is on hospice,
Mhm.
we seriously are not able to provide in-home health care an awful lot. In fact, I have a client right now who just got her second amputation, and she's not allowed to come home because she cannot get in-home health care.
Wow.
It's very, very difficult. So a lot of times they are sent to rehab facilities, and then sent home with either friends or family or someone really trying to care for their needs. Um, this particular case really bothers me because she's got so many issues going on.
So I
She
imagine
already
this is a type 2 diabetic patient that with poorly managed diabetes and bilateral below the knee amputations. Is that correct?
the person that has it actually it came from long-term COVID.
Wow.
Oh, really? Oh, wow. So this is a
Yes.
patient that that requires extensive home services.
Yes, sir. And she's actually about 30 years old.
Wow.
Oh, wow.
It's very heartbreaking.
Mm.
And
But getting her the services that she needs has been very, very difficult. And we have a lot of community organizations that work together, social service organizations that work together in our community, but this is almost like an impossible situation if you're living in a rural area.
yeah.
You really need friends and families to help intervene in this case. I also know that she has the kidney uh, dysfunction there going on. So
Oh,
this,
is she dialysis dependent?
um, only while she was under.
Oh.
She had to have dialysis while she was under.
So she's stage 4 3-year stage 4 kidney failure.
Yep.
Those patients
Uh-huh.
often at a young age, I would not be surprised if in the future she may be dialysis dependent. And you can imagine the additional complexities for that patient if they needed to go to dialysis 3 days a week.
And it's really, really difficult. I just found out that she got her second leg amputated last week, so it's very heartbreaking. But I go back to the elderly Mrs. Tiller. Mrs. Tiller has the kidney uh, disease, I believe, was said at the beginning of the case study.
Mm-hmm. Mm-hmm.
And
100%.
having kidney disease just exasperates this whole situation. If she had a lot of blood loss, her body may have a hard time making those red blood cells again. She may have to get infusions and things to help with that. There's so many complications that can happen in this woman's health. And I don't care if she's urban or rural.
Mm-hmm.
There are so many complications here. This is a truly juggling act. And
Mm.
I really believe that the family needs to make some plans for their mother. And I really believe that she needs to have a medical power of attorney should things like this
100%.
happen in the future. And I also happen to know that at this age, a person who has a hip fracture, the life expectancy averages about 2 years after the occurrence.
That is excuse me. That is 100% correct. And I really do appreciate we get to share different rural and urban perspectives here. What I can say is they are both on hard mode, but with different dynamics that are both fascinating and telling to both the complexity of the community health workers field and the daily difficulties excuse me, the daily difficulties. Coffee is best when drank, not breathed. Benvinda, you were, I think, trying to jump into the conversation at one point. Did you have
Yeah.
any thoughts you wanted to add?
Yeah, just sitting here in this training, I realize how the difference in the services and things that are available to support folks like Mrs. Terrell. And it's unfortunate, like Wendy was mentioning, the area that she serves, it's so rural, there's not really, there might be resources, but not maybe close by that the patient can get to, or the CHW can get to assist the patient more. So I'm just mind-boggling how the difference in services, and also, as you know, a lot of the states rely on state funding, and I know a lot of states don't have maybe state income tax, so a lot of our funding for the safety net hospitals and the underserved folks that we have here in the state, a lot of it is funding, whether it's, you know, tobacco taxes or what have you, um, that funds a lot of the different programs that are available here.
Mm. And
Yeah.
I find the difference in types of complexity very interesting as well. And thank you for sharing that comment, Benvinda.
Mm-hmm.
I want to grab a couple. We're getting close here. And I'm wondering if anyone knows what a DVT is and why it's important that we perform prophylaxis for DVT.
Deep
I
vein
do. Deep vein
thrombosis.
thrombosis.
Yes. Why do that sounds cool? Is that a good thing? What do those do?
That causes blood clots in the legs that can break loose and possibly travel to the lungs or the heart or so on and so forth.
100%. Is Mrs. Tiller at risk of a DVT after her surgery? And particularly a hip surgery?
100%.
Absolutely.
Mhm. She is in particularly elevated risk. And as you correctly identified, DVTs don't just lead to morbidity and mortality in one way or two ways. They do in many ways. And DVT is called a deep venous thrombosis, as you correctly identified. And it is a buildup of clotted blood in typically the great saphenous vein. They can develop in any large venous structure, and they are the result of the blood being still or the clotting cascade being interrupted either chemically or physically through the patient's procedure. People can get you are at risk. Some people are at risk of more at risk of DVTs. Others, there are set things that raise your risk. If you're sitting down for a long period of time, your venous blood is stagnating, and there is a risk of clot formation. For some, those can accumulate and become quite large over time. But when you have a clot in your deep veins, those clots can break off into little clots all of the time. It breaks into your venous system, which then goes back into your heart and gets pumped back out into the rest of your body. And some of the first places it can go is land in your heart. It can land in your brain, or it can land in your lungs, causing severe morbidity and mortality, stroke, heart attack, coronary artery disease, lung infarction. These are all relatively common sequelae of DVT. And DVT prophylaxis is a huge priority for this patient. Things you want to be up on when you see those patients. Always look at everyone's feet, particularly with people with chronic disease, feet and legs, chronic disease, conditions, type 2 diabetes, clotting disorders, and DVT risk. The patient will experience a unilateral swelling below the point of the thrombosis, and it will be in severe cases will be obvious. So keep an eye out for this, because if you're serving a patient who's recently been at risk of DVT, and that's long distance travel without moving, sitting for long periods of time, or being in the hospital, and particularly a bone fracture, be on the lookout for that unilateral swelling, for any symptom of heart attack or stroke. Be on the lookout, because those sequelae lead to long-term disability and mortality in these patients at levels that are severe, and it is a major priority issue for us, and that's everywhere. DVTs should be at the front of your mind when you see patients who have had surgery. Also, patients who have recently given birth, or have traveled, or been stagnant for a long period of time. Be aware, and keep an eye on people's feet. It'll help more often than you think. Don't be weird about it, but FYI, you can say that I said it was okay. Fide, everyone can say Dr. Lombardi said, look at everyone's feet.
Yeah.
Don't send me any pictures though. We are 1:59, so I will mute. But first, I say this has been a distinct pleasure. I will be speaking to some of you I know soon. I encourage you to reach out to each other and to reach out to me and my colleagues.
Thank you. This was so informative. Thank you to everyone here. I really appreciate this.
Thank you, and you're welcome. Thank you, everybody that joined us again. On behalf of the National Center for Health and Public Housing, we're so grateful that you were able to join all of the sessions. And to close it up, please complete our post-evaluation survey. and provide your feedback and let us know what we could do better during our next learning collaborative that we will be hosting. What topics you're looking into learning more in the future. So please let us know.
Can I just ask a quick question,
Yep.
Fide? Will any CUs ever be offered for these type of trainings through our HRSN?
At this moment, I don't have an answer.
You can help us by putting that request into the
Yeah.
feedback. That's how you can help.
Yeah, that would really help me. I know I need 15 for my upcoming license, for my CHW license. So that's why I was asking. I'm sure I'll find a few that I can attend, but I just want to.
What I will recommend is we do a lot of work with the National Nurse-Led Care Coalition. They have ongoing things that are very similar to our work. We work together with them, and they almost always provide that for nursing. It should work for you as well. And please put that in the comment, because we're actively, we ask ourselves that question often, and your feedback will help with that process. And to everyone, we love your feedback, everyone. We really are here to serve you.
Thank you, Kevin. Thank you.
Yeah, but definitely that is something that we have been discussing and considering and doing in the future. So, and I just put in the chat the name of the other organization that we collaborate with, that they also have other trainings that you could probably use for the CUs.
Okay, let me just write that down.
Also, Boston University does a lot of webinars and offer the CEUs.
Yeah, I'm gonna do one with the Boston Public Health Commission. I know they have a couple, but I was just wondering, since it's coming up very soon and I don't have a lot of time to do a lot of trainings, but maybe in the future.
The national, oh goodness, never mind. I can't think of it right now, but I'll send it to you in an email.
Okay, thank you so much.
If you
Yeah, there are a
two
few-
do not keep talking, I'm going to be disappointed. Because I have about 13 ideas of ways you can help each other.
Yeah. So
I have a lot of questions for
that'll be
Benny. I'm going to call you Benny.
sure,
I also have a
absolutely.
lot of questions for you.
That's a lot
Shoot
nicer
away.
than what she calls me. That's a lot nicer than what she calls me.
Yeah, I won't go there.
No. Hers just said we can't talk like that on the air. We gotta be polite.
Oh my goodness, you mean that organization that's being taken all apart?
They are being well led, and they are our generous grantors, and we are happy to serve their mission here.
Oh, I'm sorry. I almost went into politics. Sorry. Bye.
No politics.
Have a lovely day, everyone.
Thank you, everyone.
Someone in the chat asked for the link to the evaluation.
Oh yes, it's gonna pop on your screen as soon as I close up the Zoom.
Okay.
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 All right. Yeah. Thank you.
Thank you.
All right. Well, everybody have a good rest of your day, and then we will keep in touch. Okay. See you guys hopefully soon
you,
in our
everyone.
next training. Goodbye.
Thank you.